The next speaker is Raghuraj Hegde, and he will be speaking on optimizing outcomes and revising suboptimal eyelid reconstructions.
Yeah, thank you, Prashant. So thanks everyone for staying back. I know lunch is waiting, but I'll finish this presentation quickly, and we'll have a small panel discussion. Please stay back for that. So surgeons from different specialties attempt oral fractures and plastic, like all the plastic surgeons and ENT and maxillofacial, they attempt eyelid surgeries which are not, which often have suboptimal outcomes aesthetically as well as functionally. So there's a lack of availability of oculoplastic surgeons and trauma centers. So that is the most common reason why we have suboptimal outcomes in the first place. So, and also there's a lack of credentialing process in India as well. There's no legal limitation for any surgeon to attempt any surgery, and there's again a very poor accountability for outcomes. And training in fundamental concepts in facial trauma are lacking in India, not just in ophthalmology, but across specialties. So what keeps me in business in Bangalore is basically dog bites, like I mentioned in my previous presentation, and as well as road traffic accidents where people have very high risk behavior in Bangalore. So they drive without helmets and drive multiple two-wheelers. So this is what keeps me. And another reason why I'm in business is because many of these patients are treated by plastic surgeons and maxillofacial surgeons. So in this case, a plastic surgeon repaired an eyelid without even seeing if the canaliculus is repaired or not, and it's caused a very bad eyelid scar, and we had to go and revise that patient, and there was a ptosis as well. The levator also had to be reattached. All those things were not taken care of by the primary surgeon. So then we have this lacerations, canalicular lacerations, eyelid lacerations with using staples. So really it is very, very disturbing to see staples on the eyelid. So it's, of course, we have to do canalicular stenting, but we should not put staples on the face. I'll be speaking a few slides on scar modulation because it's very important in these kind of cases where we do use scar modulation. My treatment of choice is 5FU, 5-fluorouracil, and it has shown significant capacity of modulation in the scar following trauma, whether it is primary trauma or secondary trauma. It is proposed mechanism of action is through the inhibition of the rapidly proliferating fibroblasts, and it results in decreasing collagen deposition and scarring. It's still off-label, but there is enough evidence now that it really works. And what I generally use is a scar cocktail. It's a 9:1 ratio of 5FU and triamcinolone acetonide. I always give it perilesionally, not into the scar, because it will cause epithelial defects. So and it's best administered. What we use is a rule of 3, best used between 3 weeks to 3 months of the wound repair. And we can give it weekly or bi-weekly. Usually within 2 injections you start seeing the effect. If it is enough, we can stop at that, and then we can go up to 10 or 12 as well. So there is hardly any side effects with the use of 5FU. So a particular case that was the primary repair was done by me, but you can see that it's all macerated, and the scarring, the epithelial scarring is very high. So when after 4 weeks, there was a big scar at the eyebrow, and we started him on 5-fluorouracil, and after another 4 weeks of weekly injections, so the scar was well modulated, and we can see that at least the eyebrow, even though it's thinner, but at least it is in line, and there is no hypertrophic scar on the eyebrow. So scar massage, silicone sheets are, but it's quite impractical for a eyelid or a face scars. So what I usually use is a silicone gel, and with scar massage. The scar massage is very important. More than what material we use, the massage is the important part. So sometimes I even tell patients who are not able to get this properly, even coconut oil or Vaseline jelly is also enough to do the massaging. So just to highlight the kind of cases that we get, the 6-year-old who had dog bite and with tissue loss 3 years ago, multiple surgeries by multiple plastic surgeons. There was an upper lid graft which was rubbing on the cornea while she was closing, and she also had a severe lag of ophthalmos as well. So in this case, because of multiple surgeries, we couldn't do any lid sharing procedures from the skin side. So what I did was I removed the skin graft and separated it from the posterior lamella, and after exposing the levator palpebral superiors, so that then I took a Hughes flap kind of thing and attached it to the levator palpebral superior directly, and then after some undermining, there was still a defect left. So I used a post-auricular graft to close the residual defect there, and after 4 weeks we divided it, and now even though it doesn't look that drastically different, now she doesn't have any, there's the entropion, that was cicatrization entropion that was there, which was rubbing the cornea, is now completely gone, and even her lag of ophthalmos also improved quite significantly. So another dog bite about 2 years ago, operated by a maxillofacial surgeon. They were just suturing without any putting the pieces back together. So then he had a very bad scar running along his forehead, which is extending into the eyelid. So there was a severe lag of ophthalmos as well when he's closing. So he was having a lot of irritation of the eyelid. So what we did was basically I was more concentrating on the eyelid in the first in the surgery. So basically I separated the scar, and this was such a big defect there, and after some undermining and using a post-auricular graft, we managed to put a free skin graft and repaired it, and of course we did some scar management, but after first surgery still there was a significant superior vector which was pulling the eyelid up, and the scar at the eyebrow had to be seen, and also the alignment of the eyebrow also was wrong. So then we went in again with for another second surgery where we had to I excised the whole scar along the forehead, and then realigned the eyebrows back to where it was still, and because it was a forehead flap, we could close it fairly well, but there was still a defect that was there. So that defect was we used a post-auricular graft on the other side to close that defect, so that we could get the we could finish the anterior lamellar reconstruction. So this is how he presented to us, and this is how he was at the end of the scar treatment, as well as multiple 5FU injections as well. So his lag of ophthalmos is much better, and now there's a good contour to his eyelid as well. So again, this is another, he had a road traffic accident about 10 years ago, and it was repaired by a general ophthalmologist. He's been going from one place to the other. Nobody wanted to touch him because it was a very bad scar on both the upper lids and lower lids. So what we did was we removed the scar tissue from the eyelid, and there was a big defect like this, and so we used a post-auricular graft for repair of that defect. And he healed well post defect, but then after that problem was that he had ptosis because of that eyelid graft. So we did a silicone sling, because I did not want to do any other technique, because it is all a very scarred eyelid. So he's relatively okay with now his pupillary margin is visible, so he's happy with the visibility, and cosmetically also is much better than what it was earlier. Another case, the patient came to me about 3 months after she had her road traffic accident. It was operated primarily by maxillofacial surgeons. So they did a bony reconstruction as well. So this is the original fracture that was there, and but the bony reconstruction is not too bad. So there is done a fairly decent job of the bony reconstruction, but they paid no attention to the soft tissue repair. So the soft tissue repair, the eyelid is all over the place, and there is a big scar running all along the face, and what I am guessing is they must have used just a skin suture, and they have not done any layered suturing. So that is why there is a big scar that is coming out. It's quite intimidating to see that such a big scar in the eyelid, and so what we did was we did a multiple WB plasties, I was not sure it would work, but we did some scar modulation, did a lot of scar modulation, and also we repaired the eyelid and put it back into position so that it's aligned properly. And immediately after, this is after multiple surgeries, we had to do about 2 or 3 surgeries to get her to this position, and then of course we always do the scar modulation immediately following the surgeries. And this was at the end of the surgery. So at end of the scar modulation, of course it's a work in progress. Still there is some amount of lateral canthal dystopia, which we want to correct in the little future, but we want to give her a little time. She's not very ready for another surgery right now. So this is she's fairly happy with what we have achieved till now. But the surgeon in me is not happy. I want to do it a little bit better. So in summary, primary and early reconstructions will give best outcomes. So eyelid reconstruction is a specialized job, best left to oculoplastic surgeons. And oculoplastic surgeons as a society, we should establish some credentialing process so that not everybody is able to do it, and there's some accountability for the outcomes. And we need to, in such cases when they come to us, we have to speak to them and listen to them. And the expectation needs to be moderated, because the best we do also may not be enough at that time. So even, and also surgeon and both the patient have to take those small wins when we do get what we are trying to achieve, but we may not get the big wins all the time. Thank you very much.